You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
All righty, guys. So we're back with Spine Citations Classic. This is our third installment, and we're going to be focusing on spinal cord injury. I'm Sohum, here with you guys today from Indiana.
Hey, guys. This is Jay Fitts, back again with you guys.
And this is Jose there, Jose Chacon, the medical student from American University Integrative Science at Barbados there.
All righty, let's go ahead and get things started. A little bit of background on spinal cord injuries. All right, Jose, I'll let you take it away.
Thank you there. Basically, as you know, that the spinal cord is practically important organ, basically, that covers the neurological function from both, and you know that the spinal cord is divided to both the central and as well as the peripheral nervous system there. Of course, you know, central nervous system consists of brain and spinal cord, and the peripheral system basically goes all out to the arms and legs, etc. there. And basically, in the topic we're talking about spine injuries of the spinal cord, it really deals a lot of times, it's a bimodal distribution. Basically, it can occur in both in young and as well as also in older adults. What difference between the two is based upon the etiology. Like in the case of the younger population, usually due to high injury types, like for example, trauma, more vehicle accidents, as well as also gunshot wounds, etc. there. In the case, whereas in older population, usually it's arthritic or bone quality issue is involved there that can cause fractures or other displaced that can impinge the spinal cord there. And in terms of the epidemiology of it, it's estimated that 50% of these injuries occur at the cervical spine level, while the other occur at the thoracolumbar area. And basically, the effects of these injuries can be very debilitating in itself. Can cause, for example, neurogenic shock there, motor sensory losses issues there, and many kinds of effects respiratory, prone to infections, and then it causes pressure sores, and over time this could cause not so much a pathophysiological conditions, but also can affect psychogenically. It can cause depression, and to the point that sometimes it gives a very poor quality of life there, and basically it gives a very poor prognosis over time.
Yeah, I think that you did a very good job, hitting the high points of what spinal cord injury entails, Jose. I think that one of the things that you emphasize is the bimodal distribution, and as a PGY2 taken spine call, we see that a lot. You see young patients that come in their 20s with gunshot wounds, and these are life-changing injuries that happen in a second. And then, older patients that are already spondylitic to begin with, that have a ground level fall or a low energy MVC that, can have facet fracture dislocations and central cord syndrome and all these pathologies that we're going to touch on. So I think that's a really important point for, people who are going to be seeing this stuff clinically. So let's get into the first paper here.
Okay. For this one here, it's titled International Standards for Neurological Classification of Spinal Cord Injury. This is more so of a background of a comprehensive booklet that was created in accordance to the International Standards of Neurological Classification of Spinal Cord Injury. This was started by Kirschblum et al., and it was published in 2011 in the Journal of Spinal Cord Medicine. And the study was conducted at the Kisler Institute for Rehabilitation at the UMDJ New Jersey Medical School in West Orange, New Jersey. So basically, not your typical article, but essentially it's a booklet that gives about background information about basically how we conduct, for example, for injuries for both motor, sensory, and at what levels and what based upon presentation and so forth. And then the book itself opens up with basically some vocabulary to understand, just to start off, like, for example, tetra, paraplegic, dermatome, myotomes, sensory motor level, which for the most part, for any medical student resident, for the most part, will understand that these are very clinically significant in terms of determining the extent of the injury, at what levels and so forth, and what kind of functions that can and cannot do depending on the presentation there. And basically, this booklet gives a scale of impairment scale based upon ASIA, which stands for the American Spinal Injury of America Association there. And it goes by and gives a designated letter based upon its presentation. For example, those most severe will go from A through E, A being the most severe to E to less severe there. And basically for each, basically briefly on each one, A basically means a complete, which basically has no sensory or motor function is presented, especially at the sacral. And for B is basically means sensory incomplete, which is basically sensory but not motor function is preserved below the neurological level. And for C and D, oftentimes can be a little confused at times there, because both of them basically deals with motor incompletes and deals with motor functions preserved below the neurological level. In the case of C, is usually more than half of the key muscle function below a single neurological level, whereas in D, it's at least half of the key muscle function below their neurological levels. And of course, E is normal, basically meaning that sensation motor functions are preserved without any interaction.
I think that sorry, just to interrupt you real quick. For the ASIA classification, I think one of the important points is for the E, right? E being normal or not having a spinal cord injury. That only applies to somebody who had a spinal cord injury at some point and then progressed to being normal. Otherwise, we would all be ASIA E. So I think that's something that I actually learned while reading this paper. I thought was interesting. That I was like, oh yeah, it makes sense. I would be an ASIA E otherwise.
Yeah. And another thing, and you guys are saying it just like Jose was saying, this is like one of the few times that it's not good to be an A or have an A. All right. So the scale is actually, backwards of what some people might assume. So if you ever get this test question and you're trying to remember, is it ASIA E or ASIA A that is worse? ASIA A is a complete spinal cord injury versus E, which is, completely normal. So keep that in mind. That's just one of those things that sometimes can trick you up when you actually see the question come up.
Yeah, it's contrary to a lot of classification systems that we have to learn where, it gets progressively worse. It's like completely backwards. So I think it's a high yield point, and the OITE loves to test on this stuff.
Absolutely.
Thank you guys there for bringing the point there. And basically, from all this scale here and so forth, examination and so forth, is basically the clinical significance of the major of this is that it determines based upon the syndrome listed. And just give you some examples there, like central cord. Basically, it's a typical presentation that deals with someone in an elderly population with arthritic issues and compresses the spinal cord there. And then Brown-Schuler basically is a hemisegment, basically affects almost all symptoms on epilateral side with the uniqueness that it has pain, temperature, sensation on the contralateral side. Then you have anterior core, and basically that's not going into details. That's basically where the anterior spinal artery is ligated. They're lacking the blood supply there. As a result, causes spinothalamic and injuries there, with the preserve of pressure vibrating, essentially, because that's distributed by the posterior cord, which has no effect on the anterior spinal canal artery. And then the other two, the quinine equine and conus medialis. Oftentimes these two can be a little confusing at times because they're very similar in terms of location and so forth. But how I always remember, especially in stifle board styles, that conus equine has two unique features. One is that it has the presentation of the saddle anesthesia, basically the bilateral medial upper thighs have lack sensation there. And as well as also one particular is you do digital rectal exam shows that there's a decreased tone in the anal sphincters, which makes it because as you know, conus equine is a medical emergency. If diagnosed, has been immediately resected. Whereas conus medialis, very similar to conus medialis, is pretty mild in itself there, but certainly certainly if any kind of with these conditions, if any issues, let's say with fecal or urinary continence, is certainly is a warrant for surgical intervention. Other times it's just medical management from there. And for Doctors both Patel and Fitts, there are there times where you have these two you have patients present with either these conditions, and oftentimes that determine which is which sometimes.
Yeah, so we get consults from the emergency department all the time for rule out cauda equina, and I think just to kind of backtrack a little bit, at least from my understanding in my institution, both of these things are equivalently emergent if we're consulted for them. The main difference being between cauda equina and conus medullarius is as the spinal cord terminates at the L1, L2 level, and ends in the cauda equina, which stands for horse's tail. So all the nerve roots, the lumbosacral nerve roots, they look like a horse's tail to the whoever Greek god named it. But so the conus itself is actually still part of the spinal cord, and it has the descending tracts, the upper motor neuron tracts in it. So if you have compression at the conus, you have similar symptoms of saddle anesthesia, lower extremity weakness, urinary retention, but sometimes you have upper motor neuron signs as well, like hyperreflexia and rigidity, whereas cauda equina is pure lower motor neuron. So you may have saddle anesthesia, urinary retention, flaccid paralysis, but would not have any upper motor neuron signs. And both of those things, if consulted, by the emergency department, it's like, I better get down there and see and examine that patient as soon as possible. Yeah,
it's definitely like one of those type keywords or key phrases, lower extremity acute pain, and any kind of incontinence, bowel incontinence, or saddle paresthesias, things like that. I mean, it all of a sudden becomes an emergency, and they know it too. So sometimes they say it, and you're like, man, really? And but they they know we got to move once we hear those types of things. So anytime you have any kind of suspicion for that, first thing you need to do is of course, getting a good exam, like your own exam, but then you definitely want to get an MRI and kind of go from there. And it's good to know that both of these different syndromes do exist, but like we mentioned, they're somewhat urgent emergencies. So we need to first find out what's going on and get them to surgery as soon as we can.
Nice.
Exactly. Right. Basically, these syndromes, as you know, that these are your typical board style, but they're very clinical relevant, particularly for many med students and even residents alike there, and even those attending levels as well there. So
yep, the high yield stuff that we see on our board still that I definitely remember seeing on step 1. All right, moving along to this nice chart.
In this chart here, as you can see here, it basically gives you kind of like a survey, basically of all the nerve roots with the appropriate assessment for both motor and sensory, particularly functions like, for example, for issues, this will give you a further as a guidance to see where the issue would be, for particularly assessment for neurological levels, as well as also to see if this is considered complete or incomplete, and thus will give you the scale from 1 A to E classification there, based upon what the patient is able and not able to do in terms of the motor and sensory levels here. And then, as you can see in Index 2, it gives you kind of an algorithm. It gives you a step-by-step process, gives you to see how to go about in terms of give you the classification based upon the presentation there. And the only issue, and of course, there's one particular point I would like to bring this out, is a term we use, is called zone of partial preservation, or ZPP. Basically, what that means is that it's an area where despite having some spinal cord issue, but the is the area where there's motor preservation despite sensory issues. So this is the only issue with this one, is that this is only referred to complete injury. If it's incomplete, zone of preparation cannot be used, and thus it'd be a different classification there. So this was one of the little issues that this classification had, was dealing with completes and incompletes there. But other than that, it gives a fairly good diagram guidance to get appropriate diagnosis, classification, and then use it as for management, for both if surgical management or other non-surgical modalities is needed.
Right. I think that the importance for this chart is that I don't think any orthopedic surgeon is sitting there doing an exam and filling this out, but for the patients that have spinal cord injuries that follow up with physiatrists or PM&R doctors, this is something that they use to classify the injury, and the high yield stuff, at least from my standpoint for a clinical exam, are testing nerve roots. So which muscle groups correlate to which nerve roots, and that's something that is also available on ortho bullets and things like that, just for high yield physical exam. But I think that this is just for completeness sake to understand what goes into defining the injury level. All right, so we'll move it along, kind of keep it on the same theme. This is a paper that's published in Spine in 2005 out of Rothman Institute by Dr. Vaccaro. And this is, at the time was titled A New Classification of Thoracolumbar Injuries, with the importance of injury morphology, integrity of the posterior ligamentous complex, and neurologic status. So we'll go ahead and dive into it. So a little bit of background on the topic itself. So, thoracolumbar spine injuries have had varying classification schemes for a long period of time, but none have been very popular prior to this due to their lack of prognostic capability, or lack of cohesiveness amongst different groups. And they didn't really take into account the dynamics of the injury, how the injury occurred, or how it should be treated. So these clinicians, a large group of spine surgeons, kind of headed by Dr. Vaccaro, had this idea to present a clinically useful classification system that could describe the injuries, that was easy to remember, and that could stratify injuries by severity and potentially give a prognosis. So that was kind of the idea of why they wanted to propose this classification system. So they took several experts, I think around 40, from multiple level 1 trauma centers internationally, and kind of gathered information from all of these people via surveys and polls to determine what they thought were important factors for determining this classification system. And so they sent out these surveys at a single institution and to the spine study trauma group to determine how to get a reliable and valid classification system. So together, after these surveys were completed, they identified 3 important components to guide clinical decision-making in patients who sustain thoracolumbar trauma. And as we mentioned, that would include morphology of the injury, as you see on imaging, X-ray, CT, MRI, the integrity of the posterior tension band, or the posterior ligamentous complex, and the clinical neurologic status of the patient. So kind of going into these different categories, injury morphology. So when we see a spine fracture consult, we often get consulted for a compression fracture in a 70-year-old osteoporotic patient. And, that'll just be, the consult I get there, and they won't tell you anything about the neurologic status. Oftentimes all we have is plain films. So you don't know anything about the posterior ligamentous complex. So you have to kind of dive deeper into this. And this is also applicable to high energy MVC trauma. You'll see patients that we'll get a consult for, and they'll say, we have a patient in the trauma bays that has bilateral lower extremity numbness, obvious deformity in their ribs, and some kind of rotational deformity. And they have some trauma bay x-rays that show anterolisthesis of the thoracolumbar spinal cord, or the spinal column. And this classification system is applicable to that as well. So I think that's where this becomes useful. So they gave the different morphologies a different score. It's kind of compression fractures being the least, and then going upward from burst, rotational to flexion or extension distraction type injuries. So that kind of dictates, obviously the energy of the injury, but also the likelihood of having an associated ligamentous and neurologic injury. And then the posterior ligamentous complex is important because it's a secondary protector of the neural elements of the spine. So it consists of the supraspinous ligament, interspinous ligament, ligamentum flavum, and the capsules of the facet joints. It's been called the posterior tension band because of its role in providing, that elastic strength to the spinal column, and when it's disrupted has a high association with neurological injury because of instability. And then obviously the neurologic status is important because it could tell you whether there's been injury to neurologic elements. So these are the three components. As you can see, they're each assigned a score, and that leads to a composite score in this thoracolumbar injury classification system. So the importance of this in clinical decision making, so for me as a junior resident taking call, is it can kind of guide whether something needs to be emergently operated on or whether it could potentially be treated non-operatively. And I think that that's the beauty of this classification system. So the composite scores, as you saw in the previous slide, each different category is assigned a number, and if you're less than 3, it's highly suggestive of a non-operative injury, and then between 3 and 4 is kind of the gray area, and then if your score is above 5, it's more than likely going to need surgery. So for me, if I have like I go back to that patient I mentioned, the 70-year-old with a compression fracture, neurologically intact, probably wouldn't get an MRI to look at the posterior ligamentous complex. Their TLIG score would be 1, and I would be comfortable after getting some upright x-rays treating them non-operatively and not waking up my staff in the middle of the night. And that's partially in thanks to this classification system. So I think that this was an important thing to touch on. Jay, any pointers from?
Yeah, I mean, I think being able to read this paper and kind of see where it comes from was pretty neat because of how much we use it today. Like you said, I think it's something residents and, all spine staff, use to some extent. Now, how it was pretty much described to me, just like you said, Sohum, it's more so of a guide to let you know, possibly surgery versus not, but it's definitely not a, okay, it's a 4 or it's a 5. So 100% this person needs surgery. That's not completely always the case, but it definitely gives you a little bit more leeway. It's something you can document because it's pretty well observed, and it's used amongst all the different spine staff, and that's neuro and ortho. So it's something you can talk to your attendings with if you're talking to them over the phone, and suggest and use this as a, that's why I think this person would benefit from surgery or not. But it's not just because you have this number 100% surgery like that. I've seen some people with a 4, in which is 4 is kind of either or, but I've even seen some with a 5, and we decided to put them in a brace. So it's not 100%, but it definitely is like a guide. And like you mentioned before, it pretty much comes down to the most important pieces of this, and you can even look at the scoring. It pretty much is the posterior ligamentous complex intact and their neurologic status, and you can see that the 2s and 3s a little bit more. There's more 2s and 3s in these two groups, specifically PLC, the posterior ligamentous complex. If that's out, that's going to lead you towards surgery a whole lot more, more times than not, just because, you're pretty much thinking that this may be unstable at this point. And if it's unstable to where they can't bear weight without having an increase in deformity, it probably needs to have some kind of fixation. And even the higher scores that's on like the morphology, like a distraction injury, more times than not, that's going to have some kind of PLC injury with that as well. Not 100% sure all rotational injuries do, even though you would think that there still have to be most likely some kind of injury to the posterior ligamentous complex with translational and rotational injuries, but I'm not sure if that's 100% or not. But like I said, I think this is one that you need to know. Is probably one of our more famous classifications, or more, commonly used. So it's definitely a good one to read up on and have in your back pocket if you're taking any kind of spine trauma call, for sure.
Nice. Yeah.
And I don't mind there, just one little pointer there, as Dr. Fitz mentioned there, that this classification is just like we mentioned with the spinal, the Asian classification that we mentioned. They both serve as a guide there to give you a better understanding to what modalities approaches based upon the presentation. Although it's not completely 100% there, but certainly one of the better guides to do it. It would serve your your treatment options much more specific, and they rather just wondering if this and this and that there, but certainly gives us a good guidance in order to see and to see what modality involved, and then afterwards over time there we'll follow up on it and see what improvements there from there.
Agreed.
Yep. All right, let's move it along to the next one. So this is something that I remember being tested on, and I thought that's why this is important. This is a paper from Spine in 2009 by Ito et al. Out of Japan. So this is a consecutive cohort study to look at the effects of methylprednisolone in spinal cord injuries, specifically in the cervical spine. So I guess the title of the paper is, does high-dose methylprednisolone sodium succinate really improve neurologic status in patients with acute cervical cord injuries? So basically what these guys did was, in the 90s, there was a landmark trial called the National Acute Spinal Cord Injury Study, or also known as NASCIS. And this was published in the New England Journal of Medicine, I believe, and has been widely cited as the source of why we treated patients with steroids in the past for acute spinal cord injury. So these authors, like many others, had critiques of this study due to lack of clinically significant evidence for neurologic improvement and a high incidence of reported complications with steroid administration. So they wanted to investigate further. So they looked at a 2-year cohort of patients with cervical spine injuries and treated them with methylprednisolone as long as they presented within 8 hours of surgery. So kind of some history about methylprednisolone. It's obviously a steroid that we use due to anti-inflammatory actions. It's used in brain injuries. And like I mentioned, it was used in NASCIS-2, which is a randomized controlled trial, comparing that with naloxone in placebo. So it's controversial, like I mentioned, but due to its anti-inflammatory properties was used. So the patients that were administered methylprednisolone over a 2-year period were monitored for neurological improvement, which was scored based on the ASIA classification, the detailed ASIA classification. And they looked at patients' neurologic status at time of presentation, neurologic status over time, and the development of complications. So they did that over 2 years. And then for the next 2 years, they had a group of patients with spinal cord injuries that they did not administer steroids to, and they looked at these same modalities. So total in each group, in the methylprednisolone group over 2 years, they had 38 patients, and in the non-steroid group, they had 41 patients. And I like this chart because it kind of divides up your study population's sample sizes, and there's no statistical significance in the demographic characteristics presented. So let's go ahead and see what these guys found. So they found that in these patients, there was a very small, clinically insignificant improvement in the ASIA motor score at 3 months after injury, regardless. In the MPSS group or the methylprednisolone group, there was a slightly lower score, but again, it was not statistically or clinically significant. In patients with ASIA A injuries, there was a slight improvement in ASIA motor score, again, not statistically or clinically significant. But what they did find was that there was a higher rate of complications in the methylprednisolone group. I think 18 or 19 patients ended up with pneumonia versus I think 14 in the non-steroid group. I know these are small sample sizes, probably, which is one of the critiques of the paper, but there was a statistical significance in the complication rate in the steroid groups due to this increased rate of pneumonia. So what they concluded, the authors of this paper, was that based on their consecutive cohort study, there was no evidence supporting high-dose methylprednisolone administration in patients with acute spinal cord injuries. They did have higher incidences of pneumonia, and the improvements that they saw were neither statistical or clinically significant. So I think that this was important for me because in my time of training, I remember in the past, probably as a medical student, seeing questions on, UWorld or other question banks about administering steroids. And as I actually got into residency and started seeing these patients and treating them, at least at my institution, our practice is to not give steroids in acute spinal cord injuries. I know, metastatic spinal cord injuries for oncologic mets are different, and but specifically for trauma, we don't give steroids at my institution. So I was kind of interested in the history of that. And I think that for those of you that haven't read that original landmark trial, that NASCIS2, that's also a good one to check out.
One thing I wanted to, if I don't mind, Dr. Patel,
go ahead.
One thing to bring out is that even though this study does shows that that the use of it increased incidence for complications there, that even though despite this studies like this there, it's that methylprednisolone is still commonly used worldwide for any spinal cord injuries for it, and due to because usually they're more widely available compared to some more improvements there, but for the most part there, it's overall that it's still reliable for other things there. But certainly this is a good study to give us a guide, give us an idea that for the further treatment for these kind of patients and these injuries there. And of course, as you mentioned there, one thing I would critique on it is that it has a very low sample size, but it does serves as a foundation for these kind of modalities for as in the near future.
Yeah,
right.
And just like you're saying, I follow behind a few attendings, and I have seen some attendings prefer to use steroids, especially if it's something the patient get to our facilities within a couple of hours. They seem like they're a little bit more likely to use steroid. But so like you guys mentioned, it's small sample size, but it definitely seems to lean towards not using steroids for spinal cord injuries, especially if you're going to have a higher incidence of things like pneumonia and different pulmonary issues. So I thought it was pretty interesting because, just like you said, it is something I have seen on questions before. And up to a certain point, I mean, earlier on, I definitely was getting a little confused by, should we use this or should we not? And this paper is definitely leaning more so towards the saying no when it comes to these types of injuries. So great paper.
Yeah, I think from my understanding, and I could be wrong, but I think they stopped testing this specific topic. And I know at least for the OITE, if it's controversial, they tend to not test it. Whereas in the past, after that, that original paper in the 90s, it was kind of hammered a lot. And then once it became controversial, they seem to have stepped away from it.
Yeah, exactly. It's definitely just like you mentioned. I don't think it's going to be on the OITE. And if we saw it, it had to be on something like an Ortho Bullets or, some kind of study prep, but it's not something like that. It's not on the actual test just because you can kind of find data that may lead you to either side, depending on, what you're looking at. So, yeah.
Yeah, for sure. All right, jumping into the last one. Glad you guys are still with us. Title of this one here, Current Practice and the Timing of Surgical Intervention in Spinal Cord Injuries. So this was published in Spine as well in 2010. This was another multi-centered study primarily out of the Neuroscience Center in Toronto, Canada, by Failings et al. So again, this is another relevant one for the junior resident taking call. Seems like to be a theme for the papers that I like to pick. But this is another literature review with an objective to get expert opinion regarding the timing of surgical decompression in a variety of spinal cord injury patients. So overall, a controversial issue. Most people could probably agree, including laymen, that when you have a patient with a spinal cord injury, it would make the most sense to try to decompress it soon, urgently. But there seems to be controversy among experts. So the preliminary results of randomized trials that were conducted on this showed that there may be neurologic improvement. There's been no high impact or any well-executed randomized controlled trials on this topic. Obviously, it's hard to randomize decompression of spinal cord injury patients, and that would probably be unethical. So not something that's easy to study. But these authors wanted to know a couple of things. One being the optimal timing to decompress patients who are complete spinal cord injuries, so that present to the trauma bay or present to the ER, already at the full extent of their injury. The optimal timing to decompress patients who are incomplete spinal cord injuries. And then the other one, kind of on the expert opinion side of things, would be worldwide variability in timing of decompression for the injured spinal cord. So like I mentioned, this was a literature review. The authors of this paper did an extensive search and found multiple studies between 1995 and 2009, both actually animal and clinical studies that were relevant in decompression of spinal cord injuries. And they also sent out a survey, a 20-question survey in English to 2,000 spine surgeons across the world in various medical associations. So this is just an example of some of the studies that they looked at. I think the important thing to highlight is, like I mentioned, there's no high-level evidence. There's some, prospective cohort, non-randomized studies by some big names in here, like Dr. Vaccaro, who published that Telix paper we talked about earlier. And these are some of the things that they concluded, most of them kind of showing that there was either no consensus or that early surgery does not yield a neurologic improvement. I think one of them states that there may be neurologic improvement. And then, some of the animal studies did show improvement in early decompression, but that was, within 30 minutes of injury, which, I don't know how clinically relevant that is for human spinal cord injuries. And then the survey they sent out was 5 scenarios. I think they came up with a few clinical scenarios, and then surveyed the surgeons on how soon they would operate on this patient if they presented to them. And so these are some of the respondents, sorry. And the scenarios are listed below, but it's pretty interesting to see the variability in these pie charts and what people would say. And this is what they looked at is expert opinion. But in most cases, most of the respondents for all the scenarios ended up responding within 12 to 24 hours of the various scenarios. So you guys can go ahead and read these on your own time, but some of them are things like central cord injuries, facet fracture dislocations, thoracolumbar spine injuries, compression fractures, and their associated neurologic sequelae. So the conclusions of this paper from their widespread literature review and expert opinion were relatively unassuming, but I think they're important for us to think about as we see these patients. So they had some strong recommendations from what they qualified as moderate level of evidence using the class system of evaluating quality of evidence. And what they recommend in this is that, majority of spine surgeons would prefer to decompress any spinal cord injury within 24 hours. And that should be considered, part of therapeutic management, standard of care in any spinal cord injury patient. And then another strong recommendation, but with low level of evidence, is that in Asia A complete spinal cord injury patients, cervical spine, they prefer decompression within 12 hours or within 24, sorry. And then for incomplete cervical spine injuries, Asia B through D, they prefer decompression within 12 hours. So that would be considered very early, which makes sense. If a patient is not have a complete spinal cord injury, you wouldn't want to wait for them to progress to a complete spinal cord injury. You want to get in there and try to take care of them and maximize their chance at neurologic recovery. So their conclusions in the study were, that early decompression is safe and potentially beneficial for neurologic recovery. Most spine surgeons that responded to the survey would decompress a spinal cord injury within 24 hours. And an incomplete injury should be decompressed very early in comparison to a complete injury, which would be decompressed early. And that's kind of the conclusion that I think is important for us to highlight. So for me, the relevance of this paper is if I'm on call overnight and there's a patient with cervical spine trauma, and I see them and they have some cervical radiculopathy or signs of nerve root injury and maybe some tingling in the legs, and then I go back and see them an hour later and then they progress to bilateral upper extremity weakness, I'm going to, obviously I probably would call my staff to begin with, but I'm going to call again and say, hey, this guy needs to get upstairs now, and we need to get him to the OR as soon as possible. So I think that's probably the relevance to me. And I think another thing to point out is a lot of the times in the patients that have complete spinal cord injuries, they're often so polytraumatized that there's a lot of other things going on. So, I mean, they'll be in the shock, or we call our trauma-based shock rooms, but they'll be in there getting chest tubes, they'll be getting femoral lines, they'll be getting exploratory laparotomies, splenectomies, maybe going to IR for embolization. And then, and then on hospital day 1 or 2, we'll have a chance to stabilize their spine. But, obviously life-saving measures take precedent in that scenario. And those are the same patients that tend to have complete injuries anyway. So there's a lot of confounding variables that make this a hard thing to study.
Yeah, that's a really good point to bring up. I mean, not to mention, so when these injuries occur, they might not go directly to a level 1 center where it can actually be managed because they're in extremis and they just need to be kind of stabilized. So a lot of times these people are transferred in, and that's going to add on to the time. Just like you said, they're often hemodynamically unstable, and they require a certain amount of resuscitation before they can go to surgery. So that adds on to the time. Don't let them have, they're polytrauma patient. They have a femur fracture. I mean, a lot of times that femur gets fixed sometime before the spine is stabilized. If they can lay supine, which they will be able to usually, a lot of times the femur may even be fixed before they have their spine stabilized. And if they came in to that surgery with like some kind of pulmonary contusions, and now we didn't fix the femur, they tend to kind of take a hit from that, and it's even longer before they finally make it to the OR to get their spine stabilized. So saying all that to say, I think most surgeons agree with the, trying to get these guys their spine stabilized as soon as possible. Within 24 hours is definitely ideal, but sometimes it's just not feasible due to how long it takes them to get to the hospital versus how many other injuries they have if they're hemodynamically unstable and things like that. But I thought it was a great paper. Like you said, it's almost unethical to randomize these things, but I think this paper was done in 2010. There's also a paper in 2012 that Dr. Vaccaro was a part of as well. I think it's called STASCUS. Is surgical timing, results of surgical timing in acute spinal cord injury study. They looking at early versus delayed decompression for traumatic cervical spinal cord injuries. And this was like a prospective study. And it found that, decompression prior to 24 hours after spinal cord injury can be performed safely. It is associated with improved neurologic outcomes. So in the cervical spine, I think is a given, I think that paper kind of solidified it for a lot of people, cervical spinal cord injuries. They need to be stabilized within the first 24 hours if possible. Just like you're saying, the whole complete versus incomplete, I think sometimes I have heard some debate about that, but for the most part, at my institution, we're not necessarily coming in the middle of the night. They come in at 1. We're not trying to get there at 3 to start the surgery, but they're definitely the first case in the morning if they're clear for surgery.
Yeah, definitely. Same here. And definitely echo what you said. A lot of these guys, polytraumas, will, sit on their spines for a couple of days, and not just, we're ready to go and injury day 1, but, they're getting so many other things going on that it's just not possible to get them back and stabilized. And those are usually the guys who are complete when at presentation.
Yes, agreed.
Awesome. I think that was I really like this topic, particularly, obviously everything else we see, but trauma is something at my program we do a lot of. We take a lot of calls. So this is something I think about a lot when I'm alone overnight. And it's nice to read some of these papers and understand why I'm making some of the decisions I'm making.
Absolutely. And I hope it helped everyone else that was out there listening. I think it was a lot of high yield information in these papers. These are definitely some staples in the spine literature. We really appreciate you guys tuning in. Hope you enjoyed it. Hope you were able to get something from it. And I hope you come back for the next show. All right. Thank you, guys.
Thank you there.
Thanks, everyone.